Hello everyone, welcome to the Managing ACB Masterclass from Health Innovation Yorkshire and Humber today. We will make a start at 12:31 just to give everybody time to arrive. Just going to point out some of the welcome information. So please, can you keep your cameras and mics off during the session? It is going to be recorded. Mics and cameras will then be activated during the Q&A section. So if you have any questions while the session's going, please do put them in the chat, and some of them may be answered at that point, or we can come back to them at the end when we do Q&A. But during the Q&A session, you can then actually put your mic on and ask questions if you want to that way. But please do introduce yourselves in the chat box. So it's really nice to see where everybody is joining us from. Maybe just put which ICB you're based in and your current role, for example, and just to help us all make a few connections across the region, that'd be great. We'll just give it a minute. What time are we on?
12:30. Still,
Okay.
It's nearly 12:31. Probably another 30 seconds, I would have thought.
Right.
I'll tell you when it ticks over. It's 12:31.
Perfect. Okay, so we will just briefly go through an outline and what the objectives are from the masterclass today. So I will very quickly go through an overview of the Polypharmacy programme that we've been running for the last 3 years. So my name's Hadeel Mohamed and I am the clinical lead for the Polypharmacy programme for Yorkshire and Humber. Then Mark will do a small overview of the regional and ICB ACB score data. Then Heather Smith will go through a recap of ACB, why is it important, particularly in older people. And then Sarah is going to share some new guidelines that have been created about ACB to support clinicians, but also patient information leaflets for about ACB score and the importance of it. They've been developed within West Yorkshire. Then it'll be back to me. I'll just go through some pragmatic tips about how we approach ACB reviews in clinical practice. And then we're going to hear some examples from practice from clinicians across primary care and secondary care. And then we'll finish off with a Q&A with the expert panel. So for the main sort of outcome of today, the objective that we want everyone to have is that we know we have the skills now, we know about ACB score and why it's so important to address it, but from a practical perspective, how do we make sure that we can actually do this in practice? What's the pragmatic way of approaching ACB reviews for people that are on the ground? So we want you to go away with examples of good practice and ways to implement it in the workplace. So I'm going to hand over, oh no, this is still me. So an overview of the Polypharmacy programme. The Polypharmacy programme, the whole kind of like purpose of it is about tackling problematic polypharmacy across the system. And the way that the programme runs is by doing this through a 3-pillar approach. So the first pillar is all about population health management. This is using the data that we've got to try and risk stratify. So to make sure that we are prioritising the people that need SMRs the most. And then pillar 2 is all about education and training. So how can we upskill the workforce so that clinicians feel really confident and comfortable having conversations with patients and their caregivers about medicines, doing really good quality SMRs and feeling okay with potentially deprescribing or optimizing medications. And then the final pillar is all about that public behaviour change. And this is where we are kind of promoting that patients need to be involved as well when it comes to their medicines and making them feel more empowered and giving them tools and resources to be involved in those conversations. So that's it from me for now. I'm going to hand over to Mark to talk to us about the data.
Thank you, Hadeel. I assume you can hear me.
Yes.
Thank you. So this is data from ePact2. Anybody that works in healthcare should be able to get free access to this data, signing up via the NHS BSA authority. The chart in front of you represents all 42 sub-ICBs across the country. In purple, we have the ones in South Yorkshire, yellow, Humber and North Yorkshire, and the green are West Yorkshire. We can see there's a real mixed bag in terms of how we compare to the national average. So this is the percentage of patients on with a score of 6 or more that are on an anticholinergic medicine. Next slide, please. So this is the numbers for each of those three for each of the ICBs. So we can see that each ICB has a very similar number of patients in that bucket. So just over 2,500 for South Yorkshire. And then if we look down at Humber and North Yorkshire, who are below the national average, it's just over 2,200. If we go on to the next slide, we can see what the trend looks like for anticholinergic burden for those three areas. What's great to see is that all three areas look like we have got a bit of a downward trend, which is very encouraging. We're just going to drill down now and just look at the sub-ICBs for those three ICBs. So if we look at West Yorkshire, we can see that we have more challenges in terms of the patient numbers in the Wakefield and Bradford area. And we can see that at the other end of the chart, Leeds have actually quite a low number in comparison to the national average. If we look at the trend data for this, and I think this is really interesting, and Heather may be able to touch on this when we get to the Q&A session. I know a lot of work's been done in the Leeds locality around managing anticholinergic burden, and you can see their yellow trend line is very significantly come down, which is really good to see. But the whole of West Yorkshire has seen a decrease. If we then go on to the next sub-ICB, so South Yorkshire, we can see they're all above the national average. What I'm not presenting here is anything about your demographics, though. So there may be different factors in each of these areas. So trends next for me, Hadeel, if you could just bring that up. But again, what's really encouraging to see is we have got downward trends for those areas within South Yorkshire. We'll make these slides available, and if anybody wants any more details on data, please let me know. Looking at the final area, Humber and North Yorkshire, we can actually see that the four of the sub-ICB locations are well below the national average. We've got two just above, and looking at the trends there, like the other two ICBs. Next slide, please, Hadeel. We can see there is a bit of a downward trend, maybe not so much, but the opportunity for improvements might be less because quite a few of the sub-ICBs were already well below the national average. As I say, these slides will be available afterwards, and if anybody has any questions on the data, I'd be happy to take them later on. Thank you, Hadeel.
Yeah, thanks, Mark. So that takes us over to Heather. I'm going to let you introduce yourself.
Thank you, Hadeel. Hi, I'm Heather Smith. I'm a consultant pharmacist for older people based at West Yorkshire ICB, but my clinical practice is in the Leeds area. Next slide, please. So I'm just going to do a brief recap. So we've already had one masterclass on anticholinergic burden. So I'm just going to briefly recap that in 2 slides. So as most of you will be aware, many medicines have anticholinergic properties, and the diagram on this slide just illustrates some of the adverse effects from anticholinergic medicines. But in older people, they cause these additional adverse effects such as confusion, dizziness and falls. And there is an association with an increased risk of dementia and an increased risk of mortality, although it's not been proven that the anticholinergic medicines are the absolute cause of those. There are different calculators available to work out your anticholinergic burden, so that these calculators just add up all the scores from the individual medicines to calculate that overall burden, and medications are usually assigned a score of between 0 and 3. Obviously, the higher the score, the higher risk of adverse drug reactions, and as a sort of general guide, a score of 3 or more is associated with increased cognitive impairment and mortality. But it's a guide, it's not an absolute, and obviously you need to think about the patient's circumstances and their goals and wishes when you're reviewing these medicines. So there are a couple of calculators on the slide there. These are the ones that we tend to use most in West Yorkshire. So the ACB calculator looks at peripheral and central effects of anticholinergic medicine. So you tend to get a higher score if you use ACB because it's looking at peripheral and central. MediCheck looks more at central effects, so the impact on cognition, for example. So you'll tend to get a lower score if you use MediCheck. Next slide, please. So what do we do where we've got patients with high anticholinergic burden? So obviously we need to review those medications, and if there isn't a need for the medication, then we should discontinue it. Obviously having a shared decision-making conversation with the patient. If we can't stop the medicine, it may be appropriate to switch to an alternative medicine that has a lower anticholinergic burden score. And if we are stopping certain medicines, we need to think about potential withdrawal effects. So particularly some of the antidepressants, for example, we would need to reduce slowly, and we need to warn people of side effects that they may get from stopping their medicines. And also when we're reviewing anticholinergic medicines, it's useful to actually ask the patient if they're experiencing side effects and be quite specific about that. So ask if they've got constipation, have they got blurred vision, have they got dizziness, have they noticed any problems with their memory? Because often people don't associate these side effects with their medicines. They think they're just happening naturally. And as with anything, it's about having that shared decision-making conversation with the patient. So asking them what matters to them, what are their health goals, and what are they using their anticholinergic medicines for? Do they think they're working? Do they think they're helping? And having that shared decision about what we do next. So you're glad to know that's all for me on the recap. And I'll hand back to Hadeel.
Thank you, Heather. That was very concise. Thank you. So we are now going to hear from Sarah Mitchell-Gears about the West Yorkshire ACB guidelines that have been put together. Thanks, Sarah.
Thank you, Hadeel. Hi, welcome everyone. My name is Sarah Mitchell-Gears. I work as Principal Pharmacist for Older People's Mental Health at Bradford District Care Trust, and I also chair the West Yorkshire ACB Task and Finish group. And it's with this group that we've generated and created the guidelines for anticholinergic burden and the patient leaflets that I'm going to talk to you about today. Next slide, please. So, that's me. I've just done that one. Thank you. Next slide, please. So this link takes you to the web page, which is on the West Yorkshire Health and Care Partnership website. And we've got some new guidance and, as I mentioned, the anticholinergic burden patient information leaflets on there. So when you progress through the web page, if you do the next slide, please, Hadeel, it will give you important information about the side effects of anticholinergic medicines, what are the risks, how you can avoid these risks, and what to do if you're taking anticholinergic medicines, and who to contact, and where to gain this support, which clinicians to speak to. Next slide, please. So the accessibility function on the web page is really, really clever. It allows you to translate the web page into over 100 different languages. So next slide, please, Hadeel. You can translate it from any language, from Arabic to, if you go to the next slide, to Welsh, and all languages in between, and different font sizes as well for anyone that has problems with their vision. If you want to go to the next slide, please, Hadeel. Embedded within the web pages are our anticholinergic information, and these are principal formats. So we've got the medicines leaflet, which I'm showing on the next slide. I'm not going to go through the leaflet. It's there to be printed out and for you to have a look at. This is just really to show you where to access this information and what is actually there on the web pages. Next slide, please. We've got the easy read leaflet, which is like a two-sided document, can be folded and given to a patient if you print it out. Unfortunately, these can't be printed in numerous languages because they're embedded as PDFs, but the actual web pages are available in the different languages. Next slide, please. Yeah, that's the other side of the leaflet, and then we go through to the guidance for clinicians, which is also on a link in the web page. Now, this guidance has been created by members of the West Yorkshire Tax and Finish group. They've put a lot of work in. We've been careful not to advocate any of the calculators because NICE don't recommend a particular calculator, but we have put the links in there for the two that are most commonly used in West Yorkshire, and Heather's already mentioned those. It's just easier for a clinician to have that link at hand if they are reviewing patients' medicines. So if we progress through the leaflet, through the guidelines, there's a clever flow chart there that will indicate what stages to go through as a clinician when you're doing those medicine reviews. These can be used by primary care clinicians and secondary care clinicians, and they can be used by prescribers, by pharmacists, reviewing medicines at ward level or out in the ICBs and PCNs, so it applies to everyone. The next slide is quite useful as a table here. So it's giving alternatives. So if you're thinking about initiating a new medicine or wanting to switch a medicine for a patient that's complaining of side effects, it gives you some alternatives to think about with lower anticholinergic burden scores. So, and that's it really. The next one is just the references, and it's extensively referenced at the end. But these have all been approved by the West Yorkshire Area Prescribing Committee and are live on the web pages, and literally hot off the press. Only the last week or two they've gone live. So there you go. Just to introduce you to them. Thank you very much. Thank you, Hadeel.
Thanks, Sarah. Just to point out, we will put the link for this. It's in the, I want to say it's in one of the last slides as well, so you'll be able to access it. And even if you're not working in West Yorkshire, you'll still be able to access it through the website. But thank you for that, Sarah.
On the top of a few of the slides, actually, Hadeel, at the beginning.
Okay.
I've put it on the top of the web page slides. So yeah, it appears on two of the slides already. Thank you.
Thank you. No, that's great. Thank you very much. So then now on to my slides about taking a pragmatic approach to ACB reviews. So this is really just, I suppose, using the information that we've already got. So we've heard from Mark about the data and how that's important. We've heard from Heather about why we take this focused kind of approach to ACB score and why it's so important, particularly in older people, to identify those medicines and try and deprescribe if possible. And then now we've had that guidance for clinicians and to support patients to have those conversations with us from Sarah. How do we bring that all together and create this pragmatic approach to doing ACB reviews? So if we look at the data first, how do we actually use the data that's then presented to us? So when you look at those bar charts, depending on where you are working, some of them may have been quite a bit above the national average. And when you look at that initially and see the numbers of patients, it can seem quite overwhelming and a bit like, this is quite a lot of work. How are we actually going to tackle this? It feels like too much. But I see it as it being all about your perspective. So rather than seeing it as a challenge that's maybe too hard, the numbers are too high, what's the point of bothering with this because it takes a long time, see it as an opportunity for improvement. So the data is really good at pointing us in the direction of patients that will benefit the most from the interventions that we're going to apply. So we know that we don't have the time to do SMRs for everybody, even if we wanted to. So why don't we make sure that the SMRs that we do undertake are on the people that will benefit the most from them, will get the most impact, and there'll be the most value. And that's why the data is so useful, because it helps us to really focus on the people that need it the most and improve the care in our area. So I think there's two ways of going about this. You can take a targeted approach, which is where you would get that data, run it down to sort of patient identification, so down to their NHS numbers, and print that off and systematically work through that list. You would get all the patients that were taking medicines with an ACB score of 3 or more, 6 or more, however you ended up, where you cut that threshold, and you would then book all of those patients into your SMR appointments, for example. Now that requires you having the time and resource to block out that time and dedicate it to it, but it's a targeted way of making sure that all the patients are addressed, and you will probably complete it quicker and reach kind of that sort of target of lowering those numbers in a sort of faster way. Then there's also the opportunistic approach, which is where you may not have the resource to do that, and you've already got clinics booked for the next 6 to 8 weeks with SMRs already booked in there. And rather than thinking, well, we can't do this work, there's nothing that I can do about this now, everything's already booked in, we've got lots of other work to be getting on with. This is where I think we've got the chance to change the way we work instead and opportunistically still address ACB score. So if you, for example, suggest to your team that, okay, we know that having a high ACB score in older people is something that we want to try and avoid. We've already got SMRs booked in. Why not just change our approach and make sure that we calculate ACB score for every patient that's already booked in? We're already counting these people, but let's make it count each time we do. So when we're doing that SMR, calculate ACB score and address it as part of the review that we were already going to do. And that way you're opportunistically approaching the problem. So there is no right or wrong way of doing it. They are both effective ways of approaching the problem using the data. But like I said, it very much depends on the time and the resource that you have to hand. But I suppose my key point here is that It's about taking a pragmatic approach in that we are doing what we can with what we've got, if you see what I mean. So do the best with what you've got, whether that's a lot of resource or a little bit, but there's definitely work that can still be done. Now, the other part is about the knowledge and skills that we have. So we understand the importance of this work now, and we've got the resources to support us to do good ACB reviews, but there are still challenges in practice. So this is all good and well when you're thinking of it from a gold standard point of view, but there are challenges in practice like, you know, we might not have the resources and the time that we'd like to have. So taking a pragmatic approach to that, I've got a couple of sort of scenarios to go through about how we can still have an impact. So the first one might be that you're thinking, well, I don't have the time or the space. So this type of review needs to be in person, ideally, and it can take a long time. So I might need a 60-minute appointment for this, but how many people get that nowadays for an SMR? So it's kind of thinking about that. And yes, ideally, it would be face-to-face and it would be for an hour. But if I only have a 15-minute appointment and it's over the phone, I can still do something about this. So even if it means that when you're doing an SMR, you have to go through each medicine with the patient, that's the basis of it. So when you're going through the medicine that has that high ACB score, making sure that you're really asking about, okay, so what's this medicine for that you're taking? Do you feel like it's working for you at the moment? You know, are you getting benefit from it? Are your symptoms being managed? And working with that kind of information to then explore more with the patient at that point. And a key thing is always making sure that for that medicine in particular, we're making sure that patients are aware of the side effects. So they may not be aware already. And like Heather said before, even just pointing out to them that it could cause constipation, it could cause dry eyes, they may not have considered that before. But it is our duty to provide that information for any medicine. But in particular, when we know these can have quite, you know, really quite serious side effects, and we need to make sure people are aware of them. But that even within that short appointment, you can. Now, if the patient then comes back and says to you, actually, yeah, I really want to discuss this and I don't want to take it anymore, but you've only got 5 minutes of your appointment left, don't feel that pressure to have to sort it out in that appointment and then end up running late. It's about being able to say, look, it's really good that we've had this discussion today, and why don't we book this in for a follow-up? And that could be with you, with somebody else. It might be that the patient goes away and books it in, you might book it for them, but take whatever approach you need to make sure that that then happens, but it doesn't have to happen there and then. So you can still stick to the shorter time that you've got and do it in another appointment. Another issue that we have is that you might have had this wonderful discussion with a patient, but actually they don't want to reduce it in the end or deprescribe. Even with the information that you've given them, they make an informed choice to continue with that medicine. And I suppose that's just about us accepting that that's okay. If we've given the information to the patient, we've gone through the correct processes of shared decision making, and they decide that they want to continue, well, they need to. It might be the only medicine that can treat the condition they're on. They might have tried other medicines with lower ACB scores before and they haven't been effective. Then it's okay, and it's the right decision at that point for that patient to continue with that medicine. So it's just kind of accepting, I suppose, that sometimes we might go through the motions, but it doesn't give the result that we were expecting. That's okay. The right result is one that's best for the patient, rather than necessarily reducing the score. And then lastly, just to mention how sometimes you can actually successfully reduce the dose of an anticholinergic medicine, but just remember that the ACB score stays the same even after a review. And that can be a bit disheartening, especially if you've started off looking at the data and you want to see this reduction in trend or numbers in your bar chart. You might not see that reflected in the numbers, but just to remember that this is clinically really valuable, and for the patient, they have benefited. So it's had an impact on them, even if it doesn't impact the numbers. So to make sure that I suppose our agenda going in isn't just about reducing the score, it's about supporting the patient to get the most out of their medicines, and even if that means reducing the dose instead of completely stopping it, that's actually a win still. So just to really quickly summarise as some top tips, use the data as a guide. So like I said, the data is fantastic at highlighting where our problem areas are and what we should focus on, but don't get too hung up on the numbers. If every time you do a review, it doesn't lead to a reduced score, not to worry about that. It's the clinical impact and the impact on the patient that's important. To encourage people as much as possible to calculate ACB score routinely, if you can make this behaviour change within your teams and amongst ourselves, that when we become It's part of normal practice that when I've got an older person in front of me, I'm calculating ACB score just to check and to enter that on the record so that we can kind of like the person before you knows where they were at before and what they're at now. Now, they're not, the calculators aren't embedded within GPIT systems yet, but if you're lucky enough to have Ardens, apparently it's on the ACB template there, but they are easily accessible and they don't take as long to calculate as you think it does. And I think we'll hear about that shortly anyway, from one of our other speakers. And patient education, I can't emphasize this one enough. Even if you have a 5-minute encounter with somebody, if you can just point out to them possible side effects of that medicine, because they really may not know, you could be the person that plants that seed at that point, and they may later on come and speak to you again, or the next time they see another clinician, mention it to them, or go and find out about it themselves. Being able to give them that patient information leaflet that Sarah has talked about, and they go away and read it in their own time and come back, that's also fine. So using the small amount of time that we might have, but to give a big impact through that patient education. And then lastly, just to make sure that when we are giving alternatives to patients, that they're really clear and actionable. So be prepared with what the possible options could be. And again, the document that Sarah shared, but the guidelines for clinicians, that table at the end had good alternatives to offer that have a lower ACB score. But yeah, that's it from me. I hope it was helpful. We're going to now move on to practical examples from clinical practice. So hopefully this will demonstrate a lot of the things that I've just spoken about and how this has happened within our region, from our speakers today. So the first person speaking is Charlotte Wigglesworth.
Thanks, Hadeel. So basically, I ended up sort of getting a bit of an interest in anticholinergic burden scores from a meeting that we had with Mark, where he came and presented to our local PCN pharmacist meeting, and seeing the data and realizing that actually we had these elderly patients that, you know, had really high ACB scores and the risks associated with that. I thought, something I need to focus on. So it wasn't something that we could, you know, identify those patients and target them directly for us as a practice, and because of current workload. So my approach was literally during SMRs, just to have a little look at their ACB score. So if I'm doing a polypharmacy SMR, just to pop them into the ACB calculator online, and then and have a look at possible changes that could be made. To be perfectly honest, I've not really used the Ardens version, but I've just had a little play while I've been listening, and it's quite good actually. It gives you the medicines and the scores associated with them. So that's might be an easy way for some people to have a look if you do use Ardens. And then I found that probably the easiest two medicines to target are amitriptyline, because we've got a lot of elderly patients on it for pain, sometimes to help them sleep. So just a little conversation about whether actually it's making a difference to them, how the pain is, whether there's changes that we can make. And I always do ask about anticholinergic side effects. Lots of people will suffer with dry mouth, and then it's just sort of determining whether it's manageable or not. And another easy one that I've found is, particularly since Somalvia has been put onto the Doncaster formula for IBS, is hyoscine. So we seem to have a lot of people that go into hyoscine, and the ACB score's 3. So if we can get them onto, you know, if they're still having symptoms of bloating and they've got IBS, potentially switch them to Somalvia, alvarine and simeticone combination, which will reduce their ACB score by 2. It's still, alvarine does still carry 1 according to ACB calc, but it's a reduction of 2. And then looking at just things like PPIs, which you wouldn't really realise, the meprazole's got an ACB score of 1. You know, is it indicated? You know, just little things like that. And to be honest, it's sort of chipped away at our high ACB score patients, and it's made me become more aware of the risks associated with it, and just simple changes that we could possibly make to reduce that risk. But I'm more than happy to answer any questions if anybody's got any about my particular experience.
Thanks, Charlotte. So yours is a really good example of an opportunistic approach, where you couldn't just kind of go and systematically work through all the patients involved, but you've changed the way that you approach SMRs going forward, it sounds like. Yeah. So that's really helpful.
Certainly,
Thank you.
we need us as the practice to do it that way.
Yeah, that's great. Thank you.
Thank you.
So it's okay. We'll next hear from Sarah Tonnard, from Leeds Teaching Hospital. Sarah, are you here?
I am. Can you hear me?
Yes, we can.
Hi. So yeah, my name's Sarah. I'm one of the specialist pharmacy technicians for older people over at St James's Hospital. Next slide, please. So back in November 2023, we ran a pilot across our two older people admissions wards, and we wanted to increase awareness of ACB score of medication and try to reduce the use of drugs with anticholinergic activity over in Leeds. So we chose to do it on our two acute wards, and we chose any patient that had been admitted with a fall during a 3-week period who had an ACB score of above 3 on admission, and were discharged directly for those two wards. So the main objectives were to assess if medications are reviewed and optimised in primary care when flagged on an EDAN due to the ACB score being above 3 on discharge. To evaluate the time required for a pharmacy technician to calculate and document the ACB score if it was above 3 whilst carrying out the medication history process, and to determine whether adding the ACB score to a patient's electronic chart was useful for pharmacists. So all patients that were admitted with a fall were screened by myself for any ACB scoring medication, and that score was added to their meds on admission. The technician documented anything that was above a 3 and highlighted it to the pharmacist, and then the pharmacist validating the discharge medication put a request into the GP for the GP to review them once they'd gone home. Next slide, please. So over the 3-week period, we saw 27 patients who came into hospital with an ACB score of above 3. 54.5% of these patients had a reduction in ACB score on discharge. 13.6% had an increase in ACB score on discharge. This was at the time usually down to them being prescribed pain relief as a temporary measure, which obviously increased the score. 6 EDANs requested for the medication to be reviewed by the GP post-discharge, but only 1 was actioned by the GPs. And 3 of these patients, unfortunately, were readmitted with a further 4 within 4 weeks. So also using the technicians to document the score, we figured that on average it took the technician around 58 seconds to calculate the score, and then to document the full score and the full meds on admission on the system took them around 8 minutes, and that was based on an average number of medicines being 12 on admission. So realistically, it didn't impact that much on the technician's time to do this work. Next slide, please. So to conclude, highlighting the ACB scores on admission effectively increased awareness of anticholinergic medicines, facilitated medication review and contributed to a reduction in the ACB scores. It was feasible for a pharmacy technician to calculate and document the scores without significant burden on their workload. The only thing that we did find is because we didn't inform GP practices, we think this is why we didn't see a big outcome on them reviewing them post-discharge. So since we've done the project, we've now gone ahead and trained all the pharmacy technicians within our team to calculate any ACB scores for patients admitted over the age of 75. We're currently carrying out a quality improvement project on one of the wards using medical registrar, who are using our documented scores and raising these patients in MDT and working alongside pharmacists to reduce where clinically appropriate. The pharmacy team at the LGI are also now recording ACB scores for patients admitted to the older people orthopaedic wards. We're also looking at utilising the discharge medicine service to highlight any high scoring patients to put an extra step in place to raise awareness for these scores. And that's it. Thank you.
Thanks, Sarah. That's really, really useful. And I think it's important to point out that it didn't take as much time for the pharmacy technicians to calculate the score as we thought, because I think sometimes that's a potential barrier to doing it routinely, is that we think it will add a lot of time.
Yeah, it really didn't, and because the scores were there, it was utilised a lot, not just by pharmacy, but also by medics on the ward as well.
That's fantastic work. Thank you, Sarah.
No problem. Thanks.
So our next speakers are from Upper Calder Valley. So we've got Claire and Ray.
So I'm Ray. I'm one of the pharmacists from the Upper Calder Valley, and Claire hopefully, if she is about, is doing our first slide. I'm sure she is. So right, I'll crack on. So we went for like the targeted approach. So we ran reports for everybody at both of our practices in the Upper Calder Valley. Everybody with an ACB score of more than 3. We had the lovely reports for it, and then we tried to prioritise the oldest of patients, those who were frail and in care homes, patients already with dementia, those with polypharmacy as well, because they're obviously our highest risk categories.
So can you hear me now?
Yeah, we can.
Yeah, sorry. Sorry,
That's
Ray.
okay.
Thank you for steering the ship. Technical problems.
Right.
Sorry. Yeah, so as Ray, sorry to butt in, Ray. As Ray's said, we because our ACB score of over 3 was so big, we had to prioritize the patients in some way to get a grasp on the numbers and be able to actually figure out where to start. So we cross-referenced our search on System 1 with another search with those that are elderly, frail, dementia and polypharmacy, so we could really get those that we deemed as the highest risk. And then as a team, our pharmacy technicians contacted all these patients that we had identified as our high-risk ones, and invited all of those patients for an SMR. So they called them all up or sent them a letter. And at this point, they also documented in their GP notes what their ACB score was. So if they were to have any interaction with a clinician, it was there as the last entry in their journal in the System 1 notes of what their ACB score was. And then most of these patients wanted to come and speak with a pharmacist. And this is where Ray came in, and she was our designated ACB SMR pharmacist who conducted either reviews via the telephone, face-to-face, or home visits. And we found often these were not just one-off appointments, they were usually a 30-minute initial consultation with further, 3 to 4 follow-up appointments in some cases. And we also collected data for every patient we had an interaction with. So we had documented on a spreadsheet what their ACB score was pre the SMR and what it was post our interventions, and how many ACB meds they were on at the beginning versus at the end, and also if we'd reduced the dose, because as has already been said, that doesn't actually come across in a risk score reduction. And also if there'd been any side effects reported or any other comments that the patient might have said. So actually at the end of us doing all of this work, we had a really nice data set to show not just kind of qualitative but also quantitative evidence of the impact we'd had. So I'll hand over back to Ray now. Thanks, Ray.
So yeah, as Claire said, I did the majority of the reviews. So I kind of just started off blind. I kind of got thrown into it, but started off with care homes and obviously the frailer patients. So it's kind of now become part of my routine practice. Just any meds review, be it 5 minutes, be it half an hour, any of those medications like amitriptyline, like we all know, I'm trying to have these conversations with patients, regardless of whether they're buying into it or not. What I've given them the information and they can then go away and make their decisions. So there's lots of discussions around risk versus benefit. Obviously, if medications are doing the jobs that they're there for and patients need them, they're always going to be the best thing that they need. Practical switches, as has been mentioned lots of times already, where appropriate. So the solifenicins and oxybutanins to mirabegron where appropriate. And then obviously that needs follow-up to make sure people's blood pressure isn't doing anything too wacky. Medication holidays and trials without was also quite a good way of getting people to just see. Let's just see what will happen, because it might be that actually the medication wasn't doing all that much in the first place. And I found this quite commonly with incontinence medications, where patients were at the point where they were no longer continent, but still on the various medications for it. And actually it made no difference. So why take the extra tablet and have the increased risks? And then stopping medications without indication, so that they were no longer relevant. So obviously we've all seen it, again, incontinence medications with catheters. Obviously, sometimes they are appropriate if they're there for the antimuscarinic and bladder catheter retention, but most of the time they're not needed anymore. And I found some of these phrases quite helpful. So, has anybody told you about the long-term risks of the medication? And then I appreciate it's not risk of developing dementia, but the fact longer term, that sort of evidence is coming out, and whether be it cognitive impairment, but that gets a lot of people listening. And then, but also some, as everybody said, about some of the other side effects like constipation or dry eyes, dry mouth. Sometimes that's people's reason to stop the medication, because they're like, oh, this is the thing that's been a bane of my life, let's get it changed. And then, as I said before, I'd rather let them know now than further down the line, so they can make the best decision for themselves now instead of in 10 years' time.
That's great, Ray. Thank you. It's really nice to hear that you we're not just looking at the numbers, but we're thinking about the quantitative sort of the qualitative parts. So how it actually made the patients feel and the impact on them, which can sometimes get missed, I think, when we're doing projects. So that's fantastic. Thank you. Thank you, Claire, as well.
Thank you. Just to say, over the last 3 years, it's been great. We've run 6 masterclasses, community of practices, as well as local training, and lots of people who attended our national training as well. And so it's over 1,500 clinicians across Yorkshire and Humber benefited from this. It's been really good working with everybody on the programme. In terms of resources, so we've got a number of local resources. So we've got our Polypharmacy website, where this recording of the session, excluding the discussion and Q&A section, will be available. The previous ACB masterclass is also on there. We've also put the linking for the resources that Sarah went through earlier. We've got 2 great SMR videos that some of the people on the call have appeared in that we think are really useful, both for clinical teams and patients. There's also some national resources. So people may have seen that a new guide's just been published by the Health Innovation Network, the mechanics of tackling overprescribing and problematic polypharmacy. That's really useful. And then we've got more resources available on the national site. In terms of our next steps for the programme, so we're just handing over now because we're coming to the end of the 3-year programme. We will maintain the website, so all resources will be available there. We'll continue to signpost for training that's running next year. And the programme is being evaluated at the moment, so we will be sharing that publication as soon as it's available, I think probably Q2. Hadeel.
Yeah, just a very quick thank you to everybody, in particular today's speakers. Thank you for coming along, sharing your knowledge, putting those slides together. That's fantastic. But also extending that thank you to all the stakeholders that we've built relationships with over the last 3 years and have supported us and the Polypharmacy programme. So all the ICBs and sub-ICBs, the task and finish groups that we were involved with, particularly in West Yorkshire, our PPI reps, thank you very much, and just generally everybody. So there's too many people to mention, but thank you. And I think with that we can end. So please, yeah, sorry about 1 minute over, but there was a lot to fit in. So thank you so much, everybody, for attending and for contributing in the discussions.
Thank you for facilitating, Hadeel. We'll share the slides and the recording.